Good morning all. Today we are discussing about pulpectomy. Main goal of pulp therapy in primary teeth is to maintain an intact dental arch, a healthy periodontium, and vitality of the dental pulp whenever it's possible. Because the premature loss of primary teeth can cause many issues such as crowding of the permanent teeth or impaction of the permanent teeth, and it may affect the functions like phonetics and sometimes aesthetics also. So coming to the pulp treatment procedures, it is broadly divided into conservative and radicular treatment. Conservative treatment procedures include restoration with a protective base, indirect pulp capping, direct pulp capping, and pulpotomy. The radical treatment procedure is pulpectomy and root filling. Pulpectomy is defined as the complete removal of necrotic pulp from the root canals of primary teeth and filling them with an inert resorbable material so as to maintain the tooth in the dental arch. The definition is given by Matheson in 1995. According to Finn, pulpectomy is the removal of all pulp tissue from the coronal and radicular portions of the tooth. So pulpectomy means it's the removal of coronal and radicular pulp, and we have to fill the radicular area or the root canal with a resorbable material, because the primary teeth has to exfoliate and the permanent teeth need to erupt into that particular position. So the material used to fill the root canal should be resorbable, and this will maintain the tooth in the dental arch till its exfoliating time. General indications of pulpotomy are good general health and maximum cooperation of parents and patient. There are contraindications include young patients with systemic illness such as congenital heart disease, leukemia, or any immunocompromised conditions, because the pulpectomy the pulpectomized tooth can act as a source of infection. So if the patient is medically compromised, then we cannot do pulpectomy. For immunocompromised patients, we are not, the pulpectomy is not indicated. And children on long-term corticosteroid therapy. Coming to the indications of pulpectomy, include chronically irritated radicular pulp, the teeth with spontaneous or persistent pain, and the tooth should be restorable, and minimal mobility and intraradicular bone loss, presence of abscess of fistula, hemorrhage from amputation site is dark red and difficult to control, or sometimes if hemorrhage is absent. If the hemorrhage is not controllable, means it indicates irreversible pulpitis, and if it is hemorrhage is absent, means non-vital pulp. Then primary teeth without permanent successors, and the teeth should have at least 2/3 of the root length to be treated with pulpectomy procedure. Coming to contraindications, if the tooth is non-restorable, that is ghostly decayed tooth, and teeth with mechanical or carious perforation at the floor of the pulp chamber, that is if it is directly entering into the furcal area, and then excessive pathological loss of bone support and loss of normal periodontal attachment. The radiographic pictures shows the radiolucency in the furcal area and the resorption of root more than 2/3. Such cases we cannot perform pulpectomy. And in case of presence of any dentigerous or follicular cyst, or the periapical radicular lesion involves the permanent tooth bud, the follicular space of the permanent tooth bud, or less than 2/3 of the primary root structure is remaining. In such cases also we cannot perform pulpectomy. Limitations of pulpectomy in primary teeth. The primary teeth root canal morphology is different than the permanent tooth, because the root canals in primary teeth are ribbon shaped and tortuous in course. So multiple tortuous canals are present in primary teeth, and there is more number of accessory canals are also present. So the complete removal of pulp tissue from the accessory canals and this tortuous ribbon-shaped canals are almost impossible. And various morphologic configuration of the canal or curvature of the canal limits the mechanical debridement and filling of the root canal. And there is so many accessory canals present at the floor of the pulp chamber that will directly connect it to the furcal area, that is intraradicular area, and that will leads to transfer of necrotic products and toxic products into the bifurcation or trifurcation area. So these are the peculiar features of primary teeth, and that is why the pulpectomy is not indicated in case of a immunologically compromised patient, because the tooth may act as a constant source of infection. And coming to single visit pulpectomy, it's actually an extension of pulpotomy. When we decided to do pulpotomy procedure, and if we cannot control hemorrhage or the bleeding from the pulp chamber, we have to go for a pulpectomy procedure. In such cases, we can do single visit pulpectomy, and that is if the tooth is vital. Then there is an on-spot decision, as I discussed earlier, and the tooth does not show any periapical or furcation changes. That is, chronic infection is not present, means we can go for a single visit pulpectomy. Procedure of single visit pulpectomy is, first we have to give LA and then isolate the tooth with rubber dam, and then access cavity preparation. First we need to remove all the caries tooth structure and then enter the access cavity, that is pulp chamber, and then deroof the pulp chamber completely, then extirpate the pulp. Usually the extirpation of the pulp tissue is done using an H file or using reamers, then irrigate with saline, then working length should be taken. Working length radiograph should be taken by placing the files, and then file the canal or do the biomechanical preparation. This is to enlarge the canals and permit the condensation of root canal filling material. First, we need to prepare the access cavity and deroof the pulp chamber, then remove the pulp tissue, and then do the BMB using files and irrigate the canals with saline as an irrigant. Then flush out debris and dental shavings using saline, and then dry the canals using paper points. Then obturate the tooth completely and seal both coronally and radicular portion, and then place the final restoration and stainless steel cup. Fill the root canals and give the restoration, then final restoration is stainless steel cup. Multi-visit pulpectomy, it indicates when presence of infection, that is abscess or sinus is present, or non-vital primary teeth and teeth with necrotic pulp or teeth with furcal involvement, that is reducency present at the bifurcation or trifurcation area. The procedure usually completed in 3 appointments. In first visit, access opening and necrotic pulp tissue should be removed. Then close dressing is given. Then second sit 5 to 7 days apart, and then we have to do biomechanical preparation of the root canals, and if needed, we should give a intracanal medicament should be placed, and third visit obturation is done. Coming to the obturation part, in primary tooth, the obturation, the main feature of obturating material is that the material should resorb with the resorbing root of the primary teeth. The aim of obturation is to prevent recontamination of canal from either apical or coronal leakage, and to isolate and neutralize the remaining pulpal tissue or bacteria. Because the primary tooth has got so many accessory canals, we need to neutralize the pulp tissue present in that accessory canals. So many materials have been used for obturation of primary tooth. Examples are zinc oxide eugenol, iodoform-based paste, Maestro Paste, Endoplas, and calcium hydroxide iodoform mixture of paste. Ideal requirements of obturating material. The material should resorb as the primary tooth resorbs, because the primary tooth is when it is exfoliating, as the tooth root resorbs, the material, obturating material also should resorb with the root. Then it should not irritate the periapical tissue or coagulate any organic remnants, and then stable disinfecting properties should be there. And if the material is passed beyond the apex, it should resorb easily, and it should be easy to insert and remove if needed. Then it should not be soluble in water, and it should not discolor the tooth. And it should be radiopaque, and it should be harmless to the adjacent tooth or the succedaneous tooth germ if it is overfilled. Zinc oxide eugenol, it's unreinforced zinc oxide eugenol paste is used, and it is most widely used in primary teeth as the primary teeth obturating material suggested by Sweet. The disadvantages of zinc oxide eugenol are slow rate of resorption. It resorbs at a slower pace than the tooth root, and it can cause irritation to the periapical tissue if it goes beyond the periapical area. There may be inflammatory changes, and if it reaches till the developing tooth germ, then there is risk of deflection of the erupting successor tooth, especially if it reaches the follicular space. Then the antimicrobial property is reduced as the cement becomes set. In iodoform paste, different formulations of iodoform paste are available, such as KRI paste, Maestro Paste, Dept paste, and walk-off paste. This paste has got better resorbability than zinc oxide eugenol, but it can cause yellowish brown discoloration of the tooth crowns. That will lead to compromise in aesthetics. Maestro Paste, it consists of sterilized iodoform mixture of parachlorophenol, camphor, and menthol. It also includes zinc oxide and thymol and lanolin. It is used successfully for treatment of infected primary teeth, and if it is extruded from the canals, it was resorbed within 2 weeks to 3 months time, and it will not damage the succedaneous tooth if it goes beyond the periapical area. And the material is walk-off paste. Walk-off paste is introduced by walk-off in 1928. It consists of iodoform paste with vehicle for a carefully blended mixture of parachlorophenol, camphor, menthol, and can be used as intracanal dressing in case of non-vital teeth. That is, if the teeth is having large periapical lesions or large reducency in the bifurcation area, in such cases we can give this as an intracanal medicament. KRI paste, it consists of iodoform, camphor, menthol, and parachlorophenol. The properties are, it resorbs at the same rate as the root resorbs. It is harmless to the permanent tooth germ, and if it is overfilled or if it reaches the periapical area, it will resorb in 1 to 2 weeks time. And best antibacterial property, it can be easily removed and radiopaque. Pinto paste, it consists of iodoform, calcium hydroxide, caffeinated monochlorophenol. But if the concentration of each part is not proper, it will change the biological properties of the paste, and it may affect the clinical performance. Sometimes it can cause toxicity also. Next is Vitapex. It is calcium hydroxide iodoform paste that gives excellent results when used as an obturating material. It is available as premixed paste in polypropylene syringes. It's available as Vitapex, Diapex, Metapex, Galpex, etc. It's a mixture of calcium hydroxide and iodoform. Composition is iodoform, calcium hydroxide, silicone oil, and inner ingredients. It has got a faster resorption than physiologic root resorption. It is harmless, and if it is overfilled or if it is reached beyond the periapic area, it will resorb within 2 weeks. It's weak antibacterial, can be easily removed, radiopaque, and it does not cause any discoloration to the tooth. And one another disadvantage of this material is it can cause hollow tube effect. Hollow tube effect means once we have filled the root canals with this Vitapex or Metapex material, it will, because of its faster resorption rate than the physiological root resorption, it may disappear from or it may resorb from the root canals. And once, if you are taking radiograph after some time, the root canal appears as unfilled. It is known as hollow tube effect. Next is Endoplas. Endoplas is a resorbable paste which contains components similar to that of Vitapex with addition to zinc oxide eugenol. It is available as powder and liquid, and the powder consists of triiodomethane and iodine dibutyl orthocresol, zinc oxide, calcium hydroxide, and barium sulfate. The liquid portion contains eugenol and paramonochlorophenol. Advantages of Endoplas is that it only resorbs when extruded extraradicularly, and it does not wash out from the intraradicular space. That is, that hollow tube effect is not seen with Endoplas. Disadvantage is that eugenol content can cause periapical irritation and tooth discoloration if it is reached periapically. Then obturation techniques for primary tooth. So many techniques are available to carry these obturating materials into the primary root tooth. That includes endodontic pressure syringe, mechanical syringe, Lendulous spirals, Jiffy tube, tuberculin syringe, incremental filling technique, and other techniques such as using amalgam plugger or paper coins, plugging action, etc. Incremental filling technique, it's described by Gold. In this technique, thick mix of root canal filling material is prepared into a flame shape, and then it is tapped gently into the canal with the help of a plugger. But in case of curved canals or narrow canals, it is the paste cannot be placed in full working length because of the lack of flexibility of endodontic pluggers. And the repeated movement of the plugger during the paste application may increase the risk of making voids in the root canal filling material. So, canal filling. Then another technique is using Lendulous spiral instruments. It is advocated by Koppel in 1970. That is, the Lendulous spiral file is dipped into the mixture of obturating material and then introduced into the canal to its working length and then rotated within the canal. This instrument is very flexible and it allows the file to carry the paste uniformly throughout the narrow and curved canals. And it is difficult to place rubber stop in this instrument, and it is a lengthy file. The length is more than the primary root working length, so there is increased chance of instrument fracture, and there may be extrusion of the paste can happen beyond the apex. So these are the disadvantages for using Lendulous spiral instrument. Another method is using endodontic pressure syringe. It's developed by Greenberg in 1961 and described by Spedding and Karpov in 1965. It consists of a syringe barrel, threaded plunger, wrench, and it includes 30 to 30 gauge needle. This corresponds to the largest endodontic file used in the root canal. The needle available is very flexible and can be easily used in the tortuous canals of primary molars. This is the endodontic pressure syringe. And while doing obturation, the needle is placed 1 mm short of apex, and slow withdrawing type of motion, the needle is withdrawn 3 mm with each 1/4 turn of the screw until the canal is visibly filled at the orifice. Disadvantages: there is increased chance of overfill because apical resorption or the paste is applied with a pressure. Then difficulty in placing rubber stop correctly, and then it may lead the clinician to remove and reinsert the syringe repeatedly, which in turn cause displacement of paste and create voids. And it needs to be cleaned the syringe immediately after the use, and so it makes this technique more time consuming. Next method is using mechanical syringe proposed by Greenberg in 1971. A mechanical syringe with 30 gauge needle is filled with root canal filling material can be used to take the material into the obturating material into the canal. The needle is inserted up to 1 mm short of the apical foramen or working length, and then material is expressed while slowly withdrawing the needle. Jiffy tubes, it is popularized by Rippin in 1980, and the material expressed into canal by slow finger pressure on the plunger until the canal is filled till the orifice. Then another technique is using tuberculin syringe. It's utilized by Allard and Johnson in 1987. Usually, zinc oxide eugenol was backloaded into the syringe using 26 gauge 3/8 inch needle, and then the material was expressed into the canal by slow finger pressure on the plunger, and the canal was visibly filled with until the orifice. But there is difficulty in separating the tip during the injection, and which results in repeated replacement of the needle. And this may compromise the optimal filling and increase the presence of voids in the paste. As and when the needle reinserting, it can cause development of voids. Then insulin syringe technique. Here a homogeneous mixture of zinc oxide eugenol is used, and that is loaded into the insulin syringe, and stopper is used after assessing the working length. And then the needle is inserted into the canal and kept about 2 mm short of the apex. And the material is then pressed into the canal, and by doing so, the needle is retrieved from the canal outwards and continue to press the material till the canal orifice is filled. And the technique is using navy tip. Navy tip system designed to deliver paste into the root canal. It consists of flexible tip that is not easily separated from the holder. It's highly flexible needle, and it penetrates in the curved narrow canals till the apex, and it will inject the material rapidly and more uniformly. This is the diagram of navy tip syringe. Then another method is using reamers. Reamer technique. A reamer coated with zinc oxide eugenol paste or Endoplas paste is inserted into the canal with clockwise rotation and vibratory motion, and then allow the material to reach till the apex, then withdrawn the instrument from the canal in an anti-clockwise rotary motion. The stopper is placed as the according to the predetermined working length, and carry the material 5 to 7 times for each canal until the canal orifices appear filled. Then the outcomes of pulpectomy procedure. Some studies, especially done by Starkey, felt that it can cause delayed eruption of the permanent successors, and sometimes the eruption pathway is deflected, and It can cause ankylosis of the primary tooth also. Then rotary instruments in pediatric endodontics. The major concern of hand instrumentation is increased preparation time, and the child need to be cooperated for a longer period of time if we are using hand instruments. So, and another concern is inconsistency of quality of tapered preparation, and that will compromise the clinical prognosis. So the rotary instrumentation represents significant evolution in endodontics. So it will lead to a faster and safer, better quality preparation. Initially, the rotary files are fabricated with stainless steel, but later on it is replaced with nickel titanium due to better flexibility. Then nitrile files do not need free curvature because of its elastic memory and shape memory. And it can be activated and prepare the root canal with a high speed. The rotary instruments were introduced in pediatric endodontics by Barr et al. In 2000. Limitations in use of rotary instruments in primary teeth are the major concern of applying protocols of permanent teeth to primary molars is that it may lead to lateral perforation on the inner root surface, especially in case of curved molar roots. And primary tooth dentin is softer and less dense than the permanent tooth. So roots are shorter, thinner, and more curved, and undetectable root resorption is also may present. And the root canal morphology is entirely different from the permanent tooth. That is, it is a ribbon-shaped root canal morphology is seen in case of primary tooth. All these will affect the use of or limit the usage of rotary instruments in primary tooth. Disadvantages of rotary instrumentation is its cost and then increased cost of files as well as the handpiece, and then learning this technique is more skill is needed. As the pulpectomy procedure, it's very important to maintain the natural tooth. If it is pulpally involved or a large carious lesion or abscess is present, in such cases, we need to preserve the tooth by doing a pulpectomy procedure, because the best base maintainer is the natural tooth. To preserve the arch integrity, we need to perform pulpectomy or other endodontic procedure. Thank you.